Hi there, and welcome back. My name is John. I've been a patient with type 1 diabetes for the past 45 years. I'm also an ER physician in New Hampshire, and I've run a diabetes center in northern New York for about 15 years. Maybe almost 3 months ago now, this video was created to enhance diabetes awareness, share some educational topics, review some common misconceptions, experiences that I've had in life, share ideas, hints, and really just broaden the discussion on diabetes. At the same time, have some fun. So please don't take anything here as medical advice. If you find an idea or something you'd like to try, just talk to your provider. It's certainly worth a discussion. We're not giving out fraudulent ideas, but some of them might be a little bit off the beaten path. So again, enjoy the video, learn from the experiences, share your own thoughts and comments, thoughts in the comments, and we'll grow together and really have a good time. So today's a little bit different. Today, I want to talk about one of the primary molecules in diabetes, certainly the most important one to me, and also impacts type 2 patients, and that is insulin. Insulin, for a long time, was thought to only have one job in the body, but over the years, we've discovered that it has numerous impacts all over the body. So first and foremost, like we all know, and I've discussed it many times here before, insulin helps glucose go from the blood into the cell. So let's review this. Patient without diabetes has a donut. Their blood glucose starts to rise. The pancreas recognizes this in the beta cells. The beta cells are located in the islets of Langerhans, a section of the pancreas. They see the blood glucose starting to go up. They release insulin directly into the bloodstream. That insulin goes through the blood to the cells of the muscle and the fat. The doorway is called GLUT4. So it's a GLUT4 doorway or receptor. Insulin says, hey, open that door. Glucose goes in, blood sugar comes back down to the balanced level. Balance or homeostasis is occurring, and everybody's happy. So that's the primary job of insulin, or at least the job that we know the most about, is keeping the balance of the blood glucose levels. As the blood glucose levels come down, the beta cells reduce the amount of insulin they're secreting. I used to tell my patients, you blood test 3 or 4 times a day. The beta cells are constantly monitoring that number. Better than any CGMS, better than anything else. And their goal is to maintain balance. Some of the other things insulin does via these GLUT4 doors and other mechanisms is it promotes anabolism. So anabolism is the buildup, catabolism is the breakdown. You've heard about anabolic steroids, same idea. So what insulin does is it will encourage the development and creation of proteins. The way it does this is it increases the uptake of amino acids. If you remember your biology days, amino acids are the building blocks of the body, and these are used to make proteins and build. So in that way, insulin is an anabolic hormone, a building hormone. It will also work in the fat cells to increase lipids or fats. This is done through activating various enzymes, and I don't want to bore you with a ton of physiology that is confusing to everybody in the world. Thirdly, on the anabolic side, insulin will promote glycogen creation. So what is glycogen? We all know about glucose. We've talked about glucagon. Now we're going to add another player here, glycogen. Glycogen is how the muscle cells and the liver store sugar. Let me see how best to describe it. This would be what you keep in your cupboard that you might need this week, as opposed to what you keep in the pantry that you kind of forget about and get to if you need it in a couple of months. So this is the quick, easy access storage of glucose. So insulin will increase that and build things up. As far as catabolism or breaking down, insulin's going to block this. Okay, it's an anabolic hormone, so it's going to block the breaking down. First thing it does is it blocks the glycogenolysis, which is breaking down the glycogen. So if a patient, for whatever reason, can't eat, marathon runners experience this frequently, the body needs more energy, the liver and the muscle will break down that stored sugar right up in the cupboard, the glycogen, and get glucose from it. So insulin prevents that. Gluconeogenesis, another pain in the butt term, is also prevented. Gluconeogenesis is when glucose is made from other products like fats and proteins. So it prevents that. Again, remember, insulin's trying to keep the glucose levels balanced. It prevents the breakdown of fats. What we just learned on the anabolic side, it's building up fat, so naturally it's going to prevent the breakdown of fats. And it prevents the breakdown of the muscles, the protein breakdown in muscles, so we maintain a lean muscle mass. So that's the blocking the breakdown. We've seen how it promotes the building. What happens at the skeletal muscles? So the skeletal muscles are the muscles that you have control over. This would be all of the muscles that you're used to working out or flexing, okay? Not the smooth muscle, not the cardiac muscle, just in the skeletal muscles. We're going to see increased glucose uptake because insulin's knocking at that door. We're going to see more glycogen or stored sugar put up in that cupboard. So those are the anabolic portions that are affecting the muscles. More amino acids are brought in, which allows better building or development of the muscles and decreased breakdown like we saw on the catabolic side. So that's a specific activity of insulin in the muscles, both in anabolic and stopping the breakdown processes. In the fat tissues, we talked about increasing more lipid production. So we see more fat storage, otherwise known as lipogenesis. We see decreased lipolysis or fat breakdown, and we see increased glucose conversion to glycerol to produce triglycerides. So one of the reasons we monitor triglycerides in insulin dependent and type 2s using insulin, aside from the many other reasons, is it gives us an idea of the impact of the insulin being used. So just a quick, easy recap. Works at the GLUT4 door at the muscles and the liver and the fat. It promotes some buildup with proteins, with fat, and with making more stored sugar, the glycogen. It stops the breakdowns. It's doing a lot at the fat and muscle side. So this is essentially the main concept of glucose levels being balanced by insulin. Okay, the primary job of insulin that we know. Let's dive into another one. Actually, I'm going to hold off on this one because I think it's more interesting. We'll go over to the liver. So in the liver, glucose production is stopped. More glycogen is stored. So liver and muscles are your big storage areas for the glycogen. Lipids are produced. Okay, this is all stuff we've talked about. It's just this is where it happens. Okay, it also regulates your very low density lipid protein or VLDL synthesis and export. So insulin has a lot to do with your VLDL and your triglyceride levels. Okay. Moving forward to the blood vessels, the vascular system, the road to deliver nutrients and oxygen to everything in the body. Increase effectiveness of nitric oxide. Nitric oxide can sometimes be used to control blood pressure. So what we see is better blood flow, better blood pressure, increased capillary development at the level of the muscles. So why is this happening? Well, if this is a healthy patient with a good diet and good exercise levels, we want to make sure that the muscles are getting what they need. So the insulin will help promote capillary development surrounding that muscle. So instead of 2 or 3 roads delivering oxygen and nutrients to the muscle, you end up with hundreds of thousands. Much better nutrient and oxygen delivery. Keeping in mind, insulin is also promoting the build of the muscles, the anabolic side. So it's sort of creating the infrastructure to support the building that we want to do. It's almost like a political thing. Other things it does on the vascular side, on the downside of it, is chronic high insulin or insulin resistance can lead to atherosclerosis or hardening of the arteries. So I've seen this in myself. I had a wrist injury about 5 years ago. In the x-ray, a lot of my arteries lit right up because they were so calcified and full of atherosclerosis. It hasn't caused any major problems, knock on wood, but I started thinking about my development with type 1 diabetes because at the time we were purely focused on insulin to control blood glucose levels. We didn't have the ability to accurately or easily test blood glucose like we do now, especially with a sensor. So my insulin levels are probably sometimes higher than they should be. I obviously experienced low blood sugars, which we've talked about. So I'm wondering, and I've had this discussion with a couple of endos, how much of this carbohydrate use, again, that impacting education wasn't there, knowledge wasn't there. Elevated insulin levels led to my vascular system being a couple of lead pipes. Just an interesting thought, something to keep in mind. But that's how the insulin works on the transport system, the vascular system of the body. So too much insulin can cause hardening of the arteries. Appropriate levels will help get the muscles, the glucose, the energy, the nutrients, the oxygen that they need, because we're promoting development there. And nitric oxide is involved with improving the blood flow. On the reproductive side, most of this is an issue with too much insulin or insulin resistance. We know that insulin is involved with, I don't want to say regulation, but modulating the sex hormones. Okay. So when we see excessive amounts of insulin in females, we often see a total disruption of the hormones, too much androgen production. We see this in a condition called polycystic ovarian syndrome, where there'll often be some facial hair, a lot of central obesity, often infertility. So a lot of problems on the female side. On the male side, insulin resistance or too much insulin leads to decreased levels of testosterone, which, as you know, can have a huge impact throughout the body, erectile dysfunction, poor blood flow, whole lot of problems. Things, again, we often see in both type 1 and type 2 diabetes. And again, you got to wonder, is it the drug we're using to treat, or is it something else going on? And that's a whole another couple of years of video series that I'm not going to get into. So it definitely has an impact on the reproductive side. We want to balance our insulin to make sure its levels are appropriate while maintaining good blood sugars and keeping a good eye out on other impacts of reproductive issues. The immune system, the insulin just by physiology has an anti-inflammatory component to it. It will help modulate the immune cells that protect us and fight infection. Too much insulin or insulin resistance, again, can cause this chronic low-grade inflammation. We also know that the fluctuations in blood sugars that I see and other folks with diabetes see can cause free radical development and more inflammation. So insulin can be a lifesaver. It's a double-edged sword. It can also cause these other problems. So that's where it's working at the immune system. So far we've hit the whole body as far as glucose uptake, how it builds things, how it prevents the breakdown of things, the impact of the skeletal muscles, the fat tissues, the liver, all the blood vessels, the reproductive system, and the immune system. It will also work more on the endocrine side, but work with growth hormones and has a huge role in puberty. So insulin is involved in everything. There's one other system I haven't touched on yet, which I find the most interesting, and that's the brain. The brain and the central nervous system, or the central nervous system, which includes the brain and all of the communication pathways that allow us to balance, talk, speak, think, remember, function, do everything we do. Insulin is hugely involved in this. Okay, so insulin crosses through the blood-brain barrier. On the appetite side of the fence, it's going to decrease your appetite, and this makes sense. Patient without diabetes has a meal, insulin levels rise. They tell the brain, hey, we're full. We don't need to eat anymore. So that's huge, and what it's doing is activating neurons or nerves that suppress our appetite. It will also suppress nerves that stimulate our appetite. Again, the whole body works in this checks and balances system. So insulin levels go up, meaning food is coming in, tells the brain, hey, activate those nerves that make me less hungry to bring the food intake down, and then the insulin levels come back down. Insulin levels get too low, stimulates the nerves that make me hungry. Food goes up, glucose goes up, and insulin rises. So it's a nice system to maintain homeostasis or balance. Let me see. It also tells the brain that we're good as far as our appetite. And that's not so much random middle of the day hunger. It's more of eating the meal. These are the sensations that you're getting partway through your meal or all the way through your meal where, boy, I'm full. That was a good meal. A lot of that is because of insulin functioning. In obesity and in patients with insulin resistance, that whole system is blunted. We end up with what's called a reward eating pathway. Is reward based. It's an emotional fulfillment. It tastes good. It feels good. I'm getting all kinds of positive feedback, not based on the physiology of glucose levels and need to eat. And this leads to dysregulation of appetite, obesity, insulin resistance, and down a huge spiral that we've talked about a couple of times. So that's the basics of the food with it, okay? Other sides in the brain that it works on is depression and mood. Insulin will have a direct impact on depression, mood, motivation, and behavior. It's all influenced through the insulin. And when we become resistant to the insulin, oftentimes, and I'll have another video about insulin resistance, oftentimes resistance is linked to obesity and inactivity, are the two primary roles. And when we have that resistance, our risk of depression goes up, our risk of reward-based eating goes up, which, as you can tell, will feed the obesity, feeding the insulin resistance, and getting into a very vicious cycle. Insulin works with memory and learning. It helps the creation and what we call plasticity of the neurons, the adjustments of the neurons to improve our ability to learn, to improve our memory, to make things work. In fact, many scientists and researchers and doctors consider Alzheimer's disease type 3 diabetes, because in insulin resistance, we see a major issue with this, leading to Alzheimer's disease, leading to cognitive decline or ability to think and function decline that we see frequently in type 2 diabetes. So that's the big thing. It will also protect the neurons because of the anti-inflammatory component and antioxidant component. So you can see how it has a huge amount of impact in the brain, and I suspect there's a lot more that we'll discover over time. So just a quick review, because this was a ton of information. I tried to make it all fairly simple. If you have questions, please throw it in the comments. I'll be happy to respond and clarify. I'm certainly not a professional at this, but I want to make sure that the message and the ideas get across, because it is, to me, extremely interesting, because I grew up thinking insulin is all about blood sugar and that's it. So in quick review, the primary function that we are most aware of is insulin working at the GLUT4 door or receptor. It does this in the muscles, it does it in the liver, it does it in the fat cells, and insulin says, hey, glucose levels are high, take this glucose in, use that glucose for energy, use that glucose to put up in the cupboard as storage sugar, glycogen, take up these amino acids and build up the muscles, build up the fat cells, prevent fat breakdown, prevent muscle breakdown, prevent taking that storage sugar out and making more glucose. We don't need it. There's plenty in the bloodstream right now. We talked about the fat tissues, increasing the fat storage. We talked about the liver, how it's going to stop the use of that storage sugar and production of glucose from other molecules. It has a huge role with triglycerides and VLDL in the bloodstream. It's going to work with nitric oxide to dilate the blood vessels and making the flow easier. It's going to help improve blood pressure at the physiologic levels. It's going to increase capillary production around the muscles to help with the anabolic or building component. And too much insulin, insulin resistance, chronic elevated levels of insulin can lead to hardening of the arteries or atherosclerosis. Talked about the reproductive system and how the hormones, the sex hormones and the insulin as a hormone can mess each other up. Hyperinsulinemia, too much insulin, or insulin resistance can lead to infertility, polycystic ovarian syndrome, erectile dysfunction, all kinds of issues. So if you think about this, just from the male perspective, insulin resistance leading to erectile dysfunction, insulin resistance in the brain leading to depression, decreased motivation, and to reward-based eating. I can't think of a worse recipe for disaster. This hormone can spiral. As much as I love and appreciate insulin, in too much, in excess, in resistance situations, it can spiral into just a vicious, vicious, evil cycle. So just keep that in mind. We also talked about the immune system and enhancing, regulating the immune cells, the immune response, the anti-inflammatory components in the brain, the antioxidant components in the brain, how we can see chronic low-grade inflammation with too much insulin over time, the growth hormone involvement, and the development and puberty all have a lot to do with insulin. And then the biggest one, or second biggest one, I thought was the brain. The work on the mood, the motivation, the depression, the reward-based eating, the appetite suppressing, all of these things that when it works beautifully. When it doesn't work, it can go down the tubes pretty quickly. So that's insulin in a nutshell. It's a very quick, very brief review. I suspect in a year, we could probably double the length of this video as we learn more about insulin. I want to stress, we talked last week about the GLP-1 agonist hormones, injections, the Victoza, the Ozempic type medications. You can see how complicated diabetes has become, especially in the last 20, 30 years. Back in 1921, we knew that we needed insulin to reduce the blood sugar. Banting and Best discovered that. In fact, that's a video that's coming up soon. Now we have insulin working everywhere, causing all kinds of wonderful things and potentially problems. We have GIP, we have GLP-1, we have GLP-2, we have DPP-4, we have glucagon. It's just become a vicious cycle. And you can see how at some point, I think you'll probably see diabetes segregate to a specific specialization. Endocrinology now handles diabetes, and they handle it extraordinarily well. You could have a diabetologist, in other words, an endocrinologist that really focuses on diabetes, or any physician for that matter. I think over time, this is going to become so complicated and so involved, especially when you add the insulin resistance and nuances of nutrition. I think it's going to become huge, and you may see an entirely separate, I guess it would be a fellowship or even a residency at some point, who knows. But regardless, I wanted to stress to you what we know about insulin, how complicated it is, and how evil it can be. Please post any questions, any thoughts, any ideas. Again, I try to simplify things. If you have a question, don't be embarrassed. If you have it, 100 people have it, and I blew it as far as getting things out to you. So throw me the question, and I'll do my best to rehash it and help you out. If you could, subscribe to the channel. We're going to have more videos coming. We appreciate your support and love doing this for you. I always say we, and I'm wondering who the hell I'm talking about. I appreciate your support. I love doing this for you. It's a passion of mine. I'm probably the strangest ER doc in the world, but regardless, I'm going to keep doing it. So give me a like, just throw some comments down there, ideas or thoughts about this video, ideas or thoughts about videos you'd like to see, or anything from the past. If you haven't checked out the past videos, they're definitely worth it. Have a great day. Stay healthy.